بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Respected colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in the scientific event where we are here together to talk about a very important topic that is a real challenge for all of us, not only as a family physician, but also as a physician from different specialties that share the same concern of serving patients with a certain feature. So today, I would like to thank you all for attending, and I would like to thank our audience who are available with us online. There are almost 1,000 attendees. And I would like to thank Avi for giving us this wonderful opportunity to be together here tonight to share knowledge and to exchange experience about migraine. And as you know, migraine is a common and impactful, common in its prevalence and impactful in its consequences. And usually, many people, they think that migraine is just a headache. It's not a headache. It's something beyond headache. Why? Because it impacts patients with a lot of consequences and make the patients disabled. So he loses his functionalities and he loses his interest to perform his usual activities. And as we know that it is very prevalent in terms of more than 1 million people globally are affected with our patients with migraine. And usually there is almost counted to be the second leading cause of disability worldwide and the first leading cause for the disability in women. And I truly believe today, ladies and gentlemen, because we are primary care physicians and family physicians, we are well positioned in terms of being the first contact with patients. And we are almost encountering patients to tell us their story of suffering for many, many years, and a story of misdiagnosis for many years and mistreated for another many years. So it's an opportunity for us to exert our competencies, to diagnose, to treat, and to refer, if it's required, to the second level of care. So using our tools as a primary care physicians, we are not only treating patient physically as a patient with migraine, but also we are we are flipping the coin to discover what is behind migraines. So the patient's getting affected by socially and psychologically. So using the biopsychosocial model, we are in a position to transform the life of patients and to control the disease of patients and to give the patient the comfort of leading their lives appropriately and give them a hope. So today's, ladies and gentlemen, we are going to have this session to empower the primary care physician to be the frontiers in managing migraine effectively. So I would like to thank you once again, and I would like to thank our guest speakers whom we are privileged to have them with us here, representing two different levels of care, primary care and secondary care. So with all of us together, inshallah, we are going to highlight the most important part of migraine. But for the sake of giving you some introductions, I would like to mention some of the data. So I would like to thank the Saudi Society for Family and Community Medicine because they're always our scientific umbrella for having this scientific gathering. And I would like to thank our guest speaker, Dr. Badr al-Himd and Dr. Saeed al-Ghamdi, for their participation in enriching this scientific event with their thoughts and their data that they're going to give us. So this is the disclaimer. And I'm Dr. Ashraf Amir. I'm a consultant in family medicine in the International Medical Center, and I'm privileged to be a moderator for this session. So this is my disclosure. And of course, to be a very competent physician, we have to go extra mile to feel for the patient, to address the agony of the patients, and to address the suffering of the patient. And when it comes to migraine, we have to put our shoes in the patient and to understand that people with migraine, they suffer a pain that could be described like ice pick to an axis. And people, they said, their head is almost splitting into two halves. So this is the severity of the pain that we have to address and acknowledge. Not only this, but also people becoming non-functional. so they cannot perform their day-to-day activities. And imagine, with the severe pain and the loss of functionality, the total life of the patient with migraine will be totally disrupted. Not only this, but also some of the patients, they said, I just want to be in a dark room and lying down. So this is one of the features of people in acute episodic migraine, that they would like to have to be isolated and confined to certain places with total dysfunctionality and suffering from pain. And as I told you in the introductions, when we compare migraine with the other common problems that we're encountering in primary care, epilepsy is almost 50 million across the globe. There are patients with epilepsy. And when it comes to bronchial asthma, and almost 262. And when we have a diabetes, as we know, which is a very prevalent across the globe, with special focus in this country, we have almost 500,000 people with migraine, with diabetes. But how about migraine? It's have exceeded the prevalence of all other common disease that we encounter in our day-to-day practice in family medicine. So it's almost 1 billion people are affected. Out of this 1 billion people, when we look into the prevalence based on the gender, it's more prevalent in female. And it's more prevalence between the age of 15 and 49. And this is a very important clue for all of us. So a lady which coming with headache, they belong to this age group, definitely this will be the first trigger for us to think about migraine rather than anything else. And if we look into the composition of the years lived with disability, we find that it's always, again, prevalent in female, with those specific age groups more prevalence across the age between 15 and 49 years. When we look into the scale, which has been posted by the GDP in 2021, the global burden of the disease in 2021, they have identified the 10 leading causes for the global year lived with disability. So where did they position headache? It was positioned in the number 3 across the different spectrum of the 10 disabling disease. And again, when we look into the headache of migraine, it constitutes about 88%, and only tension headache comes in 11%. So majority of our patients with headache, they belong to the categories of migraine. So it is very common, very prevalent, and it should be at the top of our potential positioning in the differential diagnosis. And if we look into the total populations, it's almost 4.7% of the total year lived with disability is contributed by the migrainal headache. So imagine how many people suffer for many years across the spectrum. Let's have the flavor of looking into migraine in the Kingdom of Saudi Arabia. So again, the prevalence is more predominant in female, 36% in comparison to 24% in male. And so we can assume that every 3 patients, there is every 3 women, we have 1 woman has a migraine. And if you just look into the prevalence of the migraine across the spectrum of the age in female, it goes between 18 to almost 45 years. With a high prevalence. So it's almost comparable with the international distributions of migraine across the spectrum of gender and the spectrum of age. When we look into the Gulf regions, we find that the prevalence of migraine is almost 25% in comparison to different states and different countries. In Kuwait is 23%. So we are in a position with high prevalence of migraine. Of course, as we know that the burden of the disease is not just only headache, it's not just only pain, but it's also impaired the quality of life. It negatively impacts the personality. Those people with migraine, they have disturbed personality. They are almost anxious, excited, or they have some kind of depressions, or they are so isolated. Not only this, but also it affects the relationship between the members of the family. So 64% of the patients affected their private life, their relationship with their spouse. 37% they have a stress with the spouse, and they reduce the family activities by almost 50%. Imagine a mother who's a major member of a family having this kind of disability, which is almost 50% of her daily activities. Not only this, but also 70% affect the professional life. So it impacts the patient at work as well, and so on. So every single item that impair the quality of life is highlighted by the patient with migraine. So if we look into the WHO, when they position the categories of disability, or the categories of disability across the spectrum of seven is the highest disability rate. So severe migraine and active psychosis, dementia, and quadriplegia has been positioned to be in the category of 7 disability. So this is where we categorize migraine to be the most severe disabling clinical entities across the globe. So this is very important slide for us. Why? To tell you that the migraine people, they always try to seek healthcare professionals, and they come to emergency department as well to seek help. But the most important part here, they come to the healthcare providers more than the people without migraine. So, and they get more hospitalized more than the people that they don't have migraine. So that means they are a frequent healthcare seeker from time to time. So I have a question for you, all of you, ladies and gentlemen. Please scan the QR code and let me have your answers. So my question is, approximately what percentage of patients with migraine seek consultation in primary care setup? I'm sure that all of us, we are primary care physicians, and we come encounter frequently with those patients with migraine. So do you think that 10% of them, they come to us, or 40, 70%, or 90%? So I'll give you 30 seconds to answer this question. Please score it, and we'll see the result now. Okay, so it's the same with our attendees online. Please give your answer so we can collectively see the result. So, oops. Can we see the result, Fatma? Result ready? Right. Anyhow, we'll see the result, but I will give you the result, because it's very surprising that 70% of our patients with migraine, they come to the primary care physician. And this will shoulder on us the responsibility of managing these people. They don't go to other specialty like neurology, 28%, and others. So majority of them, they have the easy access to the primary care physician because we are there all the time. We are the gatekeeper of the healthcare system. We are the first contact with patient. People comes and tend to explain for us their suffer. So migraine is part of the holistic type of complaint that the patient comes with. So please remember that you are a very important member of the healthcare team where you can address the problem of migraine, you can diagnose, you can treat, and then you can refer if it's required. So again, when we talk about the patient journey in migraine, it's very long, lengthy journey, full of suffer and full of confusion and full of disruptions. So the patient comes with the onset of migraine, 2 to 3 migraines per month, and then he will try from time to time to self-manage by himself by using non-steroidal anti-inflammatories. And again, he will go to one of the primary care physicians to receive some of the medication. Unfortunately, it failed, and he will get his condition worsen. Then he will go to multiple primary care physicians and specialists, and then there will be some kind of failure of the treatment and insufficient management of the conditions. He will manage himself to go all the way to the emergency department to tackle this acute episodic migraine, and finally he will be landed in a specialist where he will get treated. But this is not the end of the story. The story will continue with a lot of suffer and a lot of confusions and a lot of so that's why we are in the era here where we have to work together as in a multidisciplinary team approach, in a patient-centric approach, addressing the patient need and delivering the compassionate, integrated care. So we have to be compassionate with this type of patients who really suffer. So adding sympathy and empathy and compassion to address the patient suffer, and then we treat them with our professional way. So this is, unfortunately, the appropriate treatment is always missed. And when we look into the total migraine populations in this study, which was including almost 9,000 patients, only 29% they have a medical consultation with healthcare professionals, and those who have been accurately diagnosed, they are only 20%. So imagine another 80% of the patients with migraine, they have misdiagnosed. Not only this, but also when we come to talk about the treatment, only about 8% of them, they have successfully diagnosed and successfully treated. So unfortunately, migraine is undertreated, underdiagnosed, undertreated and underdiagnosed and misdiagnosed most of the time. So not to take much of your time, so this is where we have to understand the journey of the spectrum of the disease or the natural history of the disease. So we have a prodromal symptoms, and some of the time migraine comes with aura or without aura. And then the headache, acute episodic headache, it has a feature. So where the patient usually have a unilateral throbbing, severe increase with activity, and this is the classical picture of the acute episodic migraine. And then finally, the patient will proceed to the post-dromal symptoms, which lasted for a day or two with recovery phase. I don't want to talk about much about this, but I hope that what I have said will pave the way for my colleagues who are going to talk a lot more in details about migraine and its management. So, ladies and gentlemen, on your behalf, I would like to welcome our first guest speaker, Dr. Badr bin Hamd, who has been with us for many, many years, enriching our scientific event with his expertise. And the most beautiful part, he's putting knowledge into action and practice. So Dr. Badr, he's a consultant, he's a senior consultant in family medicine. He's the chairman of the Department of Family Medicine in International Medical Center. So on your behalf, I would like to welcome you, Dr. Badr, and I would like to leave the floor for you.
Okay. Thank you, Dr. Ashraf, for your introduction. Thank you for organizing committee for inviting me, and I hope my presentation today will be practical, fruitful, and meet your expectation, bi'idhnillah. So first of all, in this presentation, I wanted to be practical by answering practical question about migraine from our practice to pave the way for my colleague, Dr. Saeed, to discuss migraine management in detail, to share with us his deep experience in dealing with this common medical problem, and finally to identify our roles as a family physician. As we know, as Dr. Ashraf said, it's almost 70%, and I can say even more, of patients with migraine attending primary care, and they seeking the help of their family physician. So the question here, is it only an adult complaint? What do you think? Is it only adult complaint? So the answer is no. So always we have also pediatric children can be affected as well. What about the types of migraine? We can divide migraine according to the symptoms. We can divide migraine according to the frequency and duration. So based on the number of days, headache days per month, we can divide migraine to acute or episodic and to chronic migraine. If the patient is having less than 15 days per month, this is mostly migraine, could be without or with aura. And if it's more than 15 days per month, mostly it's a chronic migraine. That's why we need to spend more time with our patient. We know that 10 minutes, 15 minutes in the clinic is not enough. That's why we need to spend more time, at least in the initial visit, to divide or to classify our patient. So we know that the frequency of migraine is fluid and between chronic and episodic, and we know that now that 73% of patients with chronic migraine meet criteria for episodic at least once per year. So at the end, if it's chronic migraine or if it's episodic migraine, what's the clinical significance here is how to decide about the appropriate management, especially the preventive management for our patients. So what other type of migraine that we know? We know that migraine without aura, which is the most common, there is no preceding symptoms. Migraine with aura, it's usually visual, sensory, and it comes before the headache, and sometimes the patient will have menstrual migraine as well. So we know that episodic migraine, it's more common than chronic migraine, and we are seeing this even from our practice. Almost we are talking about 91% of migraine cases in comparison to only 9 to 10% of chronic migraine. That's why it's very important every visit to reclassify and re-asking the patient again to reclassify the patient whether he is chronic or acute, and depending on that you can decide about the management. So also 90% of migraine with aura are visual, and there are different visual types of migraine. So the patient will come with different symptoms, like blindness or seeing spots or so on, as these pictures. So the patient can describe one of these symptoms, okay? And once the patient is having this and the patient is high risk, here is considered as one of the indications, at least to refer once to our colleague in neurology to exclude any TIA or stroke or any vascular disease. Moving to the most practical part, how to diagnose migraine. So even me, I cannot memorize this every now and then. So I always keep it in my mind, I keep it in my desktop, I remind myself, I spend time with my patient just to reclassify and to be sure about the diagnosis. So migraine without aura, we can diagnose it if according to the ICE HD3, so at least 5 attacks fulfilling criteria B and D. I'm not going to read it all, but at least we should know that there is a criteria for migraine without aura and for migraine with aura. So we need to have 5 attacks, headache attacks lasting 4 hours up to 3 days, and headache attacks had at least 2 of the following: unilateral location, pulsating, and this is the most common from our patient. They are describing that the headache, doctor, is pulsating. And finally, during the headache, at least 1 of the following, like nausea, vomiting, or photophobia, it will occur. And this is happening from now, sometimes with some of our patients. And this is not working. So I'll skip this. Okay, it's a question. So just to make it more practical, sometimes we don't have time, so we can go directly and just remember PIN. So if the patient is having photophobia, ask the patient, does light bother you? If the patient has impairment in their daily activity, sometimes we are assigning sick leave. What is the cause of sick leave? I have migraine. So sometimes we'll take it, okay, migraine, so what? Yes, sometimes migraine can really affect daily activity if it's severe, and sometimes the patient will have nausea or vomiting. So if 2 out of 3 question is positive, so almost the patient is having migraine. What about migraine with aura? In comparison to migraine without aura, there we need to have like 5 attacks. Here we need to have at least 2 attacks fulfilling the criteria B and C. So 1 or more of the following should be there, like visual, sensory, speech, motor, and so on. So this is, we call it aura. And at least 3 of the following 6 characteristics should be present, like, for example, 2 or more aura symptoms, at least 1 aura symptoms should be unilateral, and so on. So these criteria always, I encourage myself and all of you, keep it with you. Just remind yourself from time to time about it and reclassify your patient from time to time just to know exactly what type of migraine he's suffering from. Moving to this practical question. So what are the issues or barriers in dealing with migraine patient? In my opinion, and from practice, I can see there are 2 main problems. The first one is under or over diagnosis. Sometimes we are saying to our patient, okay, it could be like tension headache, it could be sinusitis, okay? So the patient will just keep taking the analgesic medication, and this is one of the main problems. Or sometimes we overdiagnose, so just we are labeling patient in the system, migraine, 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 and at the end, patient 100% doesn't have migraine, or what he has is cervicalgia or sinusitis or tension headache or other causes. So what is the second problem or barrier is suboptimal treatment. Suboptimal treatment could be due to you don't have the medication at your primary care or at your center, or sometimes you are not authorized to prescribe it, or you know about the medication, but still you are not competent. You don't feel that you are competent enough to prescribe it. There is a barrier to prescribe those medications. That's why we are here today to break this barrier and to talk about all the acute medication, all the preventive medication, and I can assure you, as a family physician, I'm prescribing all the acute medication, I'm prescribing all the preventive medication. We should be competent and confident enough to prescribe all of these medications. So as Dr. Ashraf said, the three main causes that really behind these barriers is, number one, the medical consultation. We're not spending time with our patient. 10 minutes to 15 minutes, more or less, we are not classifying our patient. We are not deciding about the management with our patient. That's why it's the easy way for us is to prescribe just a medication for pain. Accurate diagnosis and appropriate treatment are the three pillars or three barriers in managing patients with migraine. What are the three differential diagnoses that really mistaken with migraine or sometimes over-diagnosed with migraine? Patient coming usually with sinusitis, so nearly 90% of patients with history of sinusitis with headache, finally, they ended by having migraine. So it wasn't sinusitis, it was migraine. That's why it's very important to follow our patient. Almost nearly 90% of patients reported to have stress or tension headache. They ended by having migraine. So what's the problem with migraine? If we leave the migraine without treatment, it will progress to chronic migraine. And here comes the worst part of our story. So how to approach patient with headache? Simply, we know the history. We need to pay attention and to give more time more time asking about the history of presenting illness, screening for other symptoms, okay, especially neurological symptoms. Is the patient taking any medication or any past history of dealing with migraine with some medications, past medical history and surgical history, whatever, sinusitis, surgical history, for example. Of course, smoking, very important question. We are talking about direct and passive smoking. Psychological screening. We are talking here about anxiety, depression. Okay, the patient sometimes will not express this to you, will not give you all the information. So you need to screen for that. Of course, drug and supplement. Some patients, they like to follow the trends and they can many supplements, and there are many side effects of these supplements, including headache. Sleeping pattern. When you ask about sleeping, please ask about the sleep pattern and sleep quality. It's one of the main factors behind headache. Of course, exercise, the type and intensity is very important. Diet. Now we are in the era of asking patient about their diet. Is there any sensitivity or food allergy from that? We are just discussing now before starting the conference the relation between diet and migraine. Okay, we have what we call now food allergy test. Okay, whether you accept it or not, it's almost sensitive for most of the patient. We know that if you eat some food, it could affect even your migraine or even your headache. So is there any relation between diet and migraine? Between diet and headache, the answer is yes, there is a relation. And finally, ICE and E. What is ICE and E? Idea, concern, expectation, and effect of this problem, which is really, as Dr. Ashraf mentioned, so the effect of migraine on the patient himself, on his work, and on his family. So the next practical point, please don't forget examination. We know that we are facing many migraine patients at the clinic, and I can assure even myself, okay, we are just passing because of the time. We are not examining migraine patient. We are depending just on the history. Please examine your patient. Even if there is no clear something or no clear focus in the history for examination, at least we are talking here about the power of doctor touch. Patient wants you to touch him and to examine him, and this is part of doctor relationship, and this really has a great impact even on the management. The third practical question: do we need to do any or to order any investigation for migraine patient? Most of the time, no, we don't need, unless there is a red flag. So if there is a red flag, okay, which is neurological or other red flag, or the patient has clear history of, for example, sinusitis or other, so it depends on your history and in your examination, and even to rule out secondary causes or red flags. So what are the complications of migraine? We have main four complications like status migrainous, persistent aura without infarction, migrainous infarction, and finally migraine, which could trigger seizure. And this is very important. That's why taking deep history about the migraine history of your patient is very important. What about the secondary cause or complication or red flags, let me say? So you can remember the red flag by just memorizing SNOOP. So is there any systemic symptoms or sign like unexplained fever, history of malignancy, and so on? Is there any neurological symptoms or sign like motor weakness or headache, reach peak intensity less than 1 minute? Onset of sudden headache, like headache, as we said, headache reaching the peak less than 1 minute, or onset after the age of 50. So headache, severe headache after the age of 50 or 60, it is a red flag by itself. And finally, the pattern change. So is it progressing? Is it changing? So any change on the pattern should be raise a red flag for you. So the last question here, as a family doctor, as a primary doctor, as internist, can we manage migraine, acute and chronic, beyond paracetamol and non-steroidal, or should we refer? Doctor, this is the available. No, even if it's available, we should know it. We should offer it to our patient. So the answer is yes, we can. So the last part of my presentation, how to manage migraine. So simply, we have 3 parts to manage migraine, or 3 steps. Number 1, the lifestyle or non-pharmacological measures like regular sleep, meal, hydration, avoid the known triggers for the patient, biofeedback or CBT, of course, with acute medication and preventive medications. So what is the importance of acute medication? So American Headache Society select goals of acute medical treatment for the migraine patient, like rapid and consistent freedom from pain, restore ability to function, minimal need to repeat the dosing, optimal self-care, and reduce subsequent use of resources. So we decrease the patients. I wonder for patients, we have some patients, they are attending ER. They go to ER because of migraine. I feel sorry. Because as a family physician, this is a failure for me. Why a migraine patient is going to ER? Because he's afraid, he has severe headache, so he just going to ER. So by prescribing the appropriate medication for a patient, you will decrease the need for special care for the patient. What about the goal of preventive treatment? Preventive treatment for migraine, reduce the frequency of the attack, improve responsiveness, and avoid escalation to more and more chronic headache, improve function, reduce or poorly tolerated, ineffective, or unwanted acute treatment, so the patient will not take more. So many patients, they have like a stock of acute medication. They have sulfadine, paracetamol, and other medications. They keep trying from different acute treatment, reduce overall costs, and enabling patients to manage their own disease. So it's very important to discuss the preventive treatment for a patient, to offer it for your patient as well. So I will talk about the acute treatment quickly. So we start, of course, with non-medication like rest, cold, warm compression, adequate hydration, small amount of caffeine. If your patient is addict to caffeine, we need to talk about it. Biofeedback and relaxation technique, acupuncture, acupressure, it could help, and I believe in that, and there are many literature about this. Neuromodulation devices, there are some specific devices that really can help the patient. I don't have experience in that, but it is in the literature. People, they are using that, but maybe outside of the kingdom. Maybe Dr. Said can elaborate on this. And cupping therapy, which is wet or dry cupping therapy. It could help in some patient. So this is the well-known and the practical acute medication that we are using in our clinic. Analgesic, mostly we are using paracetamol and steroidal, mainly naproxen. Triptan group, most of the triptan group, mainly sumatriptan and L-triptan. This is the mostly used even in our clinic. The new group was a GPAN, CGRP receptor antagonist, mostly rimegepant and obrigepant. They are the mostly approved and available acute CGRP medication for acute management. Of course, you can prescribe any antiemetic for the patient if he's complaining of nausea. Ergot, dietine, and steroid, usually we are not prescribing this. Sometimes, okay, with maybe in neurology or in ER, they are taking or receiving steroid, I don't know. But usually in primary care, we don't give any of these, most of the time. So the current treatment for acute migraine, we know that there is some problem, like 50% of patients taking triptan, they have like a short relief from the pain. They need sometimes to add extra medication. Sometimes the patient will abuse the medication. We are seeing patients taking the acute medication on daily basis in addition to the cardiovascular contraindication for some acute patient. So the problem in not dealing with acute episodes and leaving the patient to have 1, 2nd, 3rd, and 4th episode, that there is a risk of progression of the episodic migraine to be a chronic migraine. So the main issues here of the acute treatment and not preventing or giving the preventive treatment is that ineffective acute treatment is associated with increased risk of disease progression. Switching among triptan does not reduce migraine disability or improve outcome. Some acute treatment should be avoided in women and, of course, in lactating and pregnant women. NSAID should be avoided in people with, of course, ulcer or people with contraindication to NSAID. Triptan sometimes is contraindicated in some cardiovascular patients. And finally, we have some patients, unfortunately, they are taken on daily basis. They are taking opioid and barbiturate, and this is really have a little effect, and the problem with dependency is there. So we need to consider all of these points in treating our patients. So when should we offer or discuss preventive medication? If the attack interfere with the patient daily routine, if the attack is frequent, failure or overuse of acute medication, if there is side effect or contraindication from the acute medication, and finally, always, please, we are talking now about shared management with our patients, so it is almost the patient preference. So I will not talk in detail about the schedule. You can find it very simple. So here you need to offer, for example, you need to offer a preventive medication for a patient with more than 3 days of headache per month with severe disability. So the patient shouldn't be chronic, but you need to ask, you need to classify, you need to ask how many attacks, and you need to ask the patient about the quality of his life after and during the migraine episode. And after that, you can decide with your patient whether your patient needs preventive medication or not. Okay, this is almost the same. So the preventive migraine treatment can be divided, as we said, the preventive to non-specific and specific migraine-specific preventive medication. We have the beta blocker, anticonvulsant, antidepressant, angiotensin receptor blocker, and ACE inhibitor. I will just discuss with you what are the important or the practical non-specific one that we are using. And in the migraine-specific, we have injectable, subcutaneous, and it's available in our center, and it's available even we are authorized to prescribe it. We have 3 subcutaneous injectable like irinoumab and others. So these are available monthly injection to prevent migraine attacks. We have the recent oral, which is rimegepant, which is every other day, and we have the atogepant, which is a daily oral treatment, and we have finally the injectable IV medications, and of course the Botox. The IV usually as a primary care, we don't prescribe an IV preventive medication for migraine. Botox, if you are trained, you can give it. Otherwise, refer please to our colleague in neurology or pain clinic. So these are the practical acute medication that we are prescribing. Beta blocker, usually we prescribe propranolol, anti-epileptic, topramate. I'm not a big fan of topramate, and it's even in neurology, I believe it's becoming less used than before. Amitriptyline still is effective really with many patients, especially if you combine it with other preventive treatment. Of course, Botox injection could be a helpful solution. So the other practical question, we are asked this question sometimes from our patient, from our colleague, can we combine CGPAN together? So the answer is yes, combining CGRP target therapy is both possible and increasingly supported in clinical practice within a limit. We'll talk about this limit in the last 2 slides. So what about combining GPANT and CGRP monoclonal antibody? So GPANT crosses the blood-brain barrier acting on the CGRP receptor, while monoclonal antibodies act peripherally on the CGRP ligand, enabling a dual blockage strategy. So the bottom line, using rimegepant or obrigepant for acute attacks while on CGRP monoclonal antibody, which is the monthly injection, is considered safe and well tolerated. What about gepant and gepant? So we have now the rimegepant, which a dual effect, not exceeding 18 tablets per month. Okay, so it can be used alone, or we have, like in this phase 4 trial, combining atogepant daily for prevention with obrigepant as needed. Okay, it can be, but we should concern about the safety. Still, there is no strong consensus about the safety of combining gepant with gepant. So when to refer, and this is my last slide, we should refer the patient. We have three division or three department to refer. Of course, we need to refer to neurology if there is any neurological symptoms, or if the patient, you cannot treat the patient is a refractory case, okay? So for further investigation. Pain specialist, if you have the pain clinic in your center, please utilize it. They have many different modality in dealing with migraine. For example, the Botox injection, nerve block, really the patient is having a great benefit from that. Of course, if there is the problem is related to ENT, you should refer to ENT, ophthalmology, orthopedic. Sometimes we forget to screen for the cervix or cervicalgia or disc. This could be one of the causes. And finally, please don't forget TMJ. TMJ, pain and trigeminal neuralgia, can be one of the underdiagnosed differential diagnoses for migraine. Thank you so much. This was my last slide.
Thank you so much, Dr. Badr, for these wonderful presentations, which you highlighted all the features of migraine with a special setup for primary care physician. I would like to say something, ladies and gentlemen. الحمد لله الذي تتم بنعمته الصالحات وتتحقق بفضله المقاصد والغايات. احنا الآن نعيش في نعمة كبيرة عظيمة لأطباء الأسرة. I remember 20 years ago or 30 years ago when we started the practice, Dr. Abdulhamid, remember, family physician, our scope was so limited to treat upper respiratory tract infection and to treat gastrointestinal tracts. And we have a very limited symptomatic treatment. Today, we can stand strong enough to see ourselves. We are in a position to have a wonderful guideline that position part of the guidelines to be confined to primary care. Not only this, the smart new molecules that we have today, like the CGRP, it become available for all of us. With a full confidence, we are prescribing this medication. With a full confidence, we are diagnosing and treating the patient completely. And this will enhance the golden statement which has been said by the American Academy of Family Physicians. The competent family physician can manage 80% of the cases. And we are here today, have been privileged with all of these kind of medications where we can treat and we can enhance the quality of life of patients, and we can change the landscape of the disease and to elevate the suffer and to improve the quality of life. Quality of life, one of the major components of our transformations of our healthcare system. So managing patients with migraine, we are improving the quality of life of patients, and this is one of the strategic goal of our transformations. So Alhamdulillah ala hadha al-fadl wal minna. So, ladies and gentlemen, I would like to introduce our second speaker, Dr. Saeed Al-Ghamdi. He's a consultant neurologist in King Faisal Specialist Hospital in Jeddah, assistant professor of medicine and neurology in King Saud. He's going to talk about the new advancement of the migraine treatment. So, on your behalf, I would like to welcome here and thank you for accepting our invitation.
Sorry. بسم الله. طيب السلام عليكم ورحمة الله. Do you have the slides? Sure, we're good, thanks. طيب أنا بستأكد كذا. طيب these are my disclosures. I have given speaks for this company, Avi, and other companies as well. طيب بسم الله الرحمن الرحيم والحمد لله والصلاة والسلام على رسول الله. I just want to consolidate one message that I have been hearing repeated by Dr. Ben Hamid and Dr. Ashraf, which is migraine in the new era should almost always be treated by family physicians. And I totally agree with this. And I want to consolidate it in a couple of ways. One is diagnosis is almost always easy. And if you misdiagnose and it turns to be later, once you treat for the patient for a month or two, it turns to be not migraine. Most of the time it's not a big deal, it's another type of primary headache. And believe me, this does happen with us as neurologists. I can't claim that every patient that I labeled as migraine almost always ended up migraine. I had few patients that I thought it's migraine, it turns to be, for example, idiopathic intracranial hypertension, especially in a young female, or tension headache, or cervicogenic headache because of a bad high cervical disc prolapse. So misdiagnosing is a concern, but I don't think it will be a huge concern for any one of you once you know the criteria and you see more patients. The other thing with the new advent of all these anti-CGRP, regardless of being promoted by this company, that all of them, they are relatively safe. There are no reported side effects, almost zero, and most of them are overall tolerable. So yes, can patient have some side effects? Yes, but most of them are minimal. I've never come across a patient who came to me complaining about any of the anti-CGRPs of any serious side effect or any intolerable side effect. So the safety issue here is a major thing that I think that should push you as family physician to be engaged more in management of migraine. So I'll start my talk, just touch base a little bit on the pathophysiology. So the pathophysiology of migraine, it's better to understand it because you're going to end up with seeing some other patient with tension headache, which is different pathophysiology, where most of the mechanism happen with peripheral nociceptive response, while in migraine it's mostly in the brain itself, or cluster headache, where it's pure trigeminal axis dysfunction with a parasympathetic dysfunction. So knowing the pathophysiology will make you a little bit at ease understanding why CGRPs or anti-CGRPs are very effective. So definitely the process almost always starts from the brainstem at the trigeminal nucleus chain, and then this will lead to release of several peptides. The most important one of them is the CGRP itself in high volume within the synaptic transmission synapse, and then this will lead to cortical activation and then cortical spread depression. So it's a brainstem, then cortical, then peripheral, then end cortical, and the cycle keeps going on and on. There are several peptides involved, but the most important one of them is the CGRPs. So here is the cycle again. So a trigeminal activation down below at the brainstem, then intense release of the CGRP at the nerve endings into the synapses, then the big pain signals goes to the cortex, then the cycle repeats itself, because this cortical activation will lead again to rebound activation of the brainstem, and the cycle keeps going. So you want to disrupt the cycle somewhere. So what happened with most of migraine treatment mechanism of action, the triptans and the ditans work at the presynaptic level, where it just tried to block the release of the CGRP itself, where all the GPANs and anti-CGRPs works at the postsynaptic level in two different pathways, either attaching itself to the CGRP ligand itself and blocking it from going to the receptor, or attaching to the receptor, so letting the CGRP by itself and blocking it from attaching to the receptor. So the GPANs, most of them, or almost all of them, the small molecule GPANs, the oral, they work at the CGRP receptor, postsynaptically. So when we established discussing the acute treatment, ergots is completely out. I've never used it, but I don't think it's licensed in Saudi Arabia, and I don't think it's licensed anywhere in the world because of the serious side effects, especially the retroperitoneal fibrosis, and then, although it's very effective. My understanding, I've never used it, by my senior colleagues that I was trained with, when they used to use it in the 70s, they claim it was extremely effective. But because of the side effects, it's out of the market almost always. The triptans seems to be effective in many cases, and the ditans, we'll discuss some of them. And then there come the CGRP antagonists and the GPANs, which is again CGRP, but mostly oral molecules. There is one of them is nasal spray as well. So, being practical, I'll skip anything that we don't use. So we're going to use simple analgesics like acetaminophen, paracetamol, NSAID. It can be almost always effective in many cases, but you're concerned about the side effect that comes with it. Then the triptans, and then now the GPANs. So when you should consider the GPAN, most of the guidelines either suggest that once the patient has ever tried a triptan, and we designate him, he or she, as non-respondent, then you should consider it. And who should you consider a non-responder? Either the patient by a validated questionnaire is unrespondent, or your attestation as a clinician, your decision as a clinician that this patient is probably not a responder. In the clinical trials, they defined most of the clinical trials that looks at triptan failure, they defined them as simple as that. So non-responder is someone who has tried the triptans 2, 3, or 4 times, and at least 2 of these times it has been ineffective. Whether it was the first time, second, third, doesn't matter. So if you tried the triptan at least 2 to 4 times, within these combination, whether 2 or 4, if you claim that the triptan was not effective in 2 out of them, that's good to establish you as a responder. So the related cost with those non-responders and those who use triptans, 2 triptans or more, and then yet they don't respond, is definitely a huge cost because of the expected recurrent visit to his primary physician or neurologist and the current ER visit as well. Can we do this? Skip it, خلاص. Because I don't know the question. بصراحة ما شفت تصدق. This is new. I didn't know what was the. Oh, here is the question. Which of the following represent an unmet need in acute migraine? Lack of efficacy with triptans طبعا. Either being lack of efficacy, recurrence of the headache, contraindication to patient with cardiovascular disease, variable response between ease, all of the above. I think it's easy. It's all above, all of them. Some different patients have different reasons. So all of the above can fit easily. So 34% claim that they have inadequate response. 43% report side effects within 24 hours. The most common side effect is a bit of a nausea and the palpitation and the flushing. But I understand most of the patients get scared by the flushing, although it's not almost always not serious. But having the flushing with the palpitation makes them worried. 30 to 40% they will have a recurrent headache within 24 hours, even if they reported response to the initial dose. And a good number of patients, especially in for example, the US, has contraindication, either it's severe hypertension, established cardiovascular disease, or peripheral vascular disease with atypical chest pain. So these are definitely contraindications. So the GPANs, these are new treatment options. They are small molecules, anti-CGRPs, oral. The 3 available in the market. The Vigipant is a nasal spray. I'm not sure if it's, definitely it's not yet Saudi FDA approved. Probably it's available in the US. Rimegepant or Progepant are available both here in Saudi Arabia. Unlike the triptans, you don't have to worry about any potential vasoconstriction. So almost always you can use it in patient even with moderate to high risk of cardiovascular disease. Hopefully, I'll come to that. They are all of them honestly seems to be very effective, but we will try to compare them. Ditans, lasmiditan, is approved in Saudi Arabia. I'm not sure if it's readily available in the market. Not yet. We're not approved? It was approved. Because I remember the company advised, and they got the FDA approval. But probably it's not going to be available, and it's not readily available because of not efficacy. It is actually, in the trials, it was very, very effective drug. But the serious side effect. You can't tell a patient, take the drug and you have to quit driving for 8 hours. That's unrealistic. And patients really report serious dizziness and like near syncope with it. So it wasn't about its efficacy, it's about its side effect. I don't think it will ever be a good option for any patient. So, and with the triptans, there is an issue with the recurrent use of triptans. It's established in the literature. If you abuse triptans and you take too much, you can end up with medication overuse headache. Can this happen with the GPAN? It might, but not yet established. We don't have any evidence that using a lot of GPANs, either one of them will give you medication overuse headache, which is a terrible headache. So the Oprogepant, if in my opinion it has anything distinct from the other, is it reached the Tmax level very fast within 1.5 hours, and its half-life, it's meaningful 5 to 7 hours. So Rimegepant seems to be effective, and it was effective in the clinical trials. If anything better is the pharmacokinetic of Oprogepant compared to the Gepant, and the relatively less reported side effect. So if you just take efficacy, they seem to be both effective within 1 and then 2 hours. But here, the Oprogepant will stick out faster action and probably less side effect, although none of them cause any serious side effect. So the cardiovascular risk, you're probably all familiar, you're definitely better than me with the Framingham risk factor. I remember it from middle school. I've never used it as a neurologist. But we have a high risk, moderate risk, and no cardiovascular risk factors. So this is, these are what the literature has shown when you use, published in the Cephalgia by, I think it was Dr. Dudek, yeah. So using the GPANs in those patients, either with high or moderate risk, or low risk, or no cardiovascular risk. If you go to any, I'm not sure if there is a pointer here, it does a point? Not working, it's okay. So if you go in the bottom, so everything is comparable. Once you say cardiovascular, you're concerned about serious adverse events. You should be reassured. It's almost, it's only in patient who took aprocibant 100 milligram, and 1.7%, and it happened in one patient on ACHIEVE-1 when also in the same dose. So it's almost always nothing. So one patient, it could be the drug, it could be something else. So nothing statistically significant between the placebo or the GBANT in terms of cardiovascular serious side effects. So I myself, I tend to use it in patients with severe hypertension, or if they have mild to moderate cardiovascular disease without any problem so far. But I don't have hundreds. I probably have 50 to 60 patients yet. So this is the ACHIEVE-1 trial, looking at this one. We're looking here at the efficacy of the trial, the drug. So ACHIEVE-1 looked at 50 and 100 milligram doses of aprocibant and versus placebo. The ACHIEVE-2 looked at 25 and 50 milligram. So 25 is not approved anywhere. I don't think it's effective. So I don't think it's readily available. So you either can use, what we use here is 100 milligram. And it also looked at the long-term safety after 12 months. So when it comes to pain freedom is no pain, free, 100% gone. Definitely the drug within 2 hours was way more effective than the placebo at the 100 milligram dose. Yeah, only at the 100 milligram dose. So that's why we probably should use the 200 milligram dose. Then 2 hours pain relief also was effective, but you're looking for freedom. But whether it's looking for pain freedom or relief, definitely the drug did way more better compared to the placebo. If you look at absence of the most bothersome symptoms at 2 hours, like the nausea, dizziness, fogginess, photophobia, phonophobia, also it was effective at the 100 milligram dose, 37.7 versus 27, yani almost 10% absolute difference, not relative, absolute. So if you compare it to relative, it will be way higher. So it was also effective at that end. If you're talking about what happened beyond 2 hours, up to 24 hours, yet still it was more effective, 38% versus 20, so almost double. And whether you're talking about pain relief or pain freedom there, it was definitely more effective, the medication versus placebo. So early intervention with the GBANs, specifically aprocibant, what's next? So the interesting thing, it's the only GBAN that has been looked at to start, and if they approve to start before the headache. So if you look in the literature, almost 70-75%, and in some data, 80% of the patients who have had migraine for 1 year or more, they tend to know the migraine is coming, and they get it right. So 80% of them, they get it right. Once they have similar symptoms, photophobia, phonophobia, sense of fogginess, some sensory complaint, 80% of the time, those patients tend to say, you know what, I'm getting a migraine, and it happens within 6 hours. So they looked into what would happen if we choose those patients and we start the medication right away before any headache. How many of them can we save from having the headache? So that's the essence of this trial. So starting the medication before getting the headache. Placebo versus aprocibant 100, you can see almost double efficacy. So double the patient on the medication versus placebo. Once they started the medication, because of these small symptoms, the headache did not occur within 6 hours. Or within 24 hours as well. This is again within 48 hours post-dose, 40 versus 24%, so it's about 15% absolute difference. And this is modified intention to treat analysis. So with the odd ratio 1.9, which is close to 2, so aprocibant is also approved if the patient, he or she knows, he has good experience that, you know what, once I have this, the headache is coming, you can tell them, you know what, if it happens, don't wait for the headache, take aprocibant right away. Hopefully the headache will not occur. So that's one unique thing about it. So the most common, these prodromal symptoms, most of them reported, you know what, I get being sensitive to light, so the headache is coming, or sensitivity to sound, or dizziness, or neck pain. Neck pain is very important because we get a lot of patients with migraine, and almost always they get neck and shoulder pain, and they keep nagging as I want an X-ray, I want an MRI of the cervical neck. So you probably have to educate them, don't worry. Migraine give you the neck pain, migraine give you the shoulder pain. So it doesn't be necessarily something here. Bye. Again, just go into safety and tolerability. If you look at the placebo versus aprocibam, there is almost no difference whatsoever, whether it's nausea, dizziness, fatigue, soundness, or any treatment-related side effect. If you look at the percentage, there is no difference. Nothing statistically different from placebo to the drug. Real-world evidence. The Kirsch trial. This is the one. This is the one that looked at combination. So, given the aprocibam, which is acute, with either botulinum toxin as preventive, whether any other anti-CGRP as a preventive, so combining two anti-CGRP, or combining anti-CGRP plus Botox. In terms of achieving pain relief, definitely the combination is better from one drug. So whether you choose to combine it with Botox, whether you choose to combine it with another anti-CGRP, whether it's injection or another oral, definitely you will have better control of the headache. And yeah, this is the same, meaningful relief, this is looking at the function, not only the pain relief. So at all levels, it has statistically significant better outcome at 2 hours and 24 hours. So here, what has all these data, how it has impacted the guidelines, the European and American. European Headache Federation, American Headache Society has both, the European I think in 2022, the American in 2024. They updated their guidelines saying that you should consider, I'm not saying you must give, but you should consider the monoclonal antibodies, whether G-PANs, oral, whether injectable, as a first line. What should limit this consideration? We probably know what is the cost, but I don't see anything else that would limit this consideration. So for me, if the cost is not an issue, it's almost always going to be anti-CGRP. I don't see any point of giving any other medication other than anti-CGRP. Someone I know who's migraine, when I know the cost is not a factor at any level. So you can, and you have guidelines approval for this, to consider these monoclonal antibodies as first-line therapy. So here what we have in Saudi, في aprocibam, في rimegepant, بعدين this is for the acute, aprocibam and rimegepant. This is what we discussed today. The rest there is for preventive therapy, but it's not the scope of our discussion today. This looked at, this is the one that Tandem looked at, given atogepant, which is plus aprocibam. So you give the atogepant every day, 60 milligram daily for preventive. You give aprocibam as needed for acute therapy. Again, there is the side effect profile combining two anti-CGRP did not result in any issue whatsoever in terms of fatigue, nausea, decreased appetite, constipation. If anything, but it's not statistically significant, but if anything, actually, the combination led to less. So, for example, fatigue. Once you have the combination, only 3 had the fatigue in the combination, and 17 had it on, which is 6.5%, 1.5%. So you cannot claim that the combination treat fatigue. I think my theory is having less headache, you're having less fatigue. Nausea actually is less. So it's not the indication treating nausea, but having less frequent headache give you less headache, then also reported less nausea. So you can see it here. For example, here nausea, 5.7% with the combination 0.9%, 6.5% for fatigue, 1.5% only with the combination. So it actually it reduces your side effect profile when you combine both compared to one. I think we're done here. This would be the last slide. So if anything, I would say anti-CGRPs in general seems to be very effective. The orals, we have 2 of them available in the market, aprocibam and rimegepant. And if anything about aprocibam is, it's if they approved to give it at the prodrome before even the headache. the side effect profile, serious, they're almost comparable, but the side effect profile like constipation, fatigue is less. And the bioavailability is definitely faster within 1.5 hours. You get the Tmax dosage or concentration. Thank you very much. I conclude. تفضل دكتور.
Thank you so much, Dr. Saeed, for this wonderful presentation, highlighting all the modalities and focusing on CGRPs and aprogepant. So now we'll open the floor, ladies and gentlemen, for the questions. So I think we'll give the preference and the privilege to the physically attending colleagues, before we get the questions from the online. Anyone in the hall? Dr. Okay. Mike, please.
Relative and absolute contraindication. Relative and absolute contraindication.
To rimegepant?
Yes.
I'm not aware of anything unless sensitivity. The patient takes it, he gets a serious sensitivity. And then they're talking about pregnancy, for example. If you're talking about side effect, I'm not aware of anything. Pregnancy, we shouldn't use any, either injectable or oral. Once the patient is established pregnant, you shouldn't use any. So that's a practical point about it, is then if you know someone who's a young lady who's not considering any contraception, probably you should give the orals, any one of the orals, rather than the injectable, because the injectable you probably need 5-6 weeks to relieve from the system. When the oral, once you stop it, I think within 3-4 days it's out of the system.
How about teenage?
Sorry?
Teenage.
Oh no, I'm talking about side effect profile. Approval, no, it's 18 plus. That's a good argument. Should it be safe? I assume, but I don't treat. Here in Saudi we treat 14 plus. So did I come across a young lady who's 16? I gave it, yes, and it went fine, but few. But I cannot say I can recommend it. I don't have it. I don't think it's approved below the age of 18 as approval. But I assume it's probably going to be safe.
Okay, Dr. Saeed, تفضل.
First of all, thank you for such nice presentations, and thank you so much. My question is, if patient already on monoclonal antibody for prevention, and he still have a partial benefit or partial controlled migraine, do you prefer to start another medication or layering with other medication for acute attacks if it happen, or use another preventive measure like Botox, or use another different molecule with the same monoclonal antibody, same class? So what would be the next step for that?
The question is of those who take a reasonable duration of anti-monoclonal antibodies, whether it's injection. So when we say injections, like the Emigality, I forgot the other one, Emovig, you probably need at least 3 doses, maybe 4. But if you take the oral, you probably need at least a month to judge. But that's a good point. Non-responders are a minority from my limited experience, but they do exist. So what would you do? What I would do, I would almost always switch to another class. So if the G-band, I might try the injection. If it's the injection, I try oral. Plus, considering Botox added. If I still believe I got the diagnosis right, because you say this is one of the things. I think one of the good things about the anti-CGRBs is if you get a patient who you give anti-CGRB, regardless which one, and he comes to you with partial response, yes, it could be migraine. But if he comes to you and say, you know what, it's nothing, it's 0, you really have to question the diagnosis. Maybe it's not migraine, maybe it's attention, maybe it's something else like idiopathic intracranial hypertension. So it actually has its diagnostic value. But I'm sorry, I'm زي الشيخ رحمة الله عليه طنطاوي. So let's go back to the question. So I would switch from injectable to oral, or I would add Botox. And the combination is okay. You can have the combination of oral and the injectable as well.
But you don't prefer to combine 2 oral together? From practice.
Excellent. 2 oral preventive?
2 oral anti-CGRP.
But preventive. No, we can do this one. For example, this one.
Like one preventive and one acute, like atogepant or rimegepant plus
definitely. But say we're talking about, in the preventive, you should use 1 plus Botox or switch. But if you want 1 acute, 1 preventive, yes, you can use both. 2 anti-CGRP, 1 acute, 1 preventive, for sure. And the trial did prove this.
Okay. Any other questions? No. Okay, Doctor. Mike here, please. Mike.
Thank you, doctor, for the presentation. If there's a patient is on preventive anti-CRGB and he's free of attacks for 1 year, can he stop the injections?
Yeah.
Yes, it depends on the patient, on the attacks. Again, you need to assess the patient. Again, you need to assess the attacks. Usually, with all the preventive medication, I would prefer to continue, okay, and to just monitor the patient. Maybe because this will decrease even the possibility or to have any acute medication. So the question, on the other hand, is it safe to continue for longer period? Yes, it is safe. So I'm going to continue, and this is my practice, okay? And there is no harm to continue unless the patient preference is to stop, okay, for any reason. So we can stop and monitor the patient. But the benefit of continuing the preventive medication is to prevent the need for ER, the need to come to the clinic for migraine, the frequency of episodic migraine, and even the need for acute medication.
Yes.
Sure. So I'm not aware of any specific guidelines that tell us you should do that or that. It's your preference. What I do, and I almost do it, whether you're happy or not, I always encourage, it's their own decision. I always encourage all to stop at 1 year. No matter what, is it anti-GRB, topiramate, Enderal, because let's face it, we see this, and we see this in practice. There are a good number of patients, they come out of migraine. We don't know why. In their late 30s and 40s, they come out of it. But it's an advice, but the decision go back to the patient. Some are willing to take the risk, so what? I get a bad headache, I'm not gonna die. I know it's a bad headache, but it's not a serious disease. I'm not gonna end up in ICU. So would take the risk to have another bad 5 days or 6 days of headache per month? Good number of patients do that, and I encourage it. And if it comes back, it comes back. The acute, no. The aprogepant, it's acute, right? Yeah. Life. There is no point. If you can afford it, keep it for life. Some people end up using it once or twice a month. But the preventive, I almost recommend 12 months and see what happens.
Dr. Said, if there is any remission for migraine, did you come across?
There is remission, yes, but there is, if you can't say there is cure, no.
Cure.
Oh, yeah. No, there is no cure, but...
Okay, so the patient lives long life.
But there is a good number of patients who, in their late 40s or 50s, they come out of migraine. They say, you know what, it used to be a disaster, now I get it once or twice every month. Mm-hmm. So for them, that's the argument. For them, why would you have to give them a preventive therapy? Maybe an acute should be good enough.
And is it a progressive disease? So it goes more
in a good number of patients, yes. So in other terms, say, how many of the patients end up with chronic migraine? Mm-hmm. Which is the most terrible thing, and medication overuse. It's up to 20-25% end up with chronic migraine. Another 15% out of them will have the chronic plus medication overuse headache, which is the worst thing ever, which is almost daily headache. But still, it's not the majority. The majority end up with episodic. Yeah. So those patients with episodic or chronic, who has been doing very well for 1 year, I'm not sure. Well, it's a patient preference. For me, I don't want to stick on a drug for the rest of my life.
So your point is not about safety. So even the preventive or the acute, it is safe even for long term.
Oh yeah. That's a good. We don't know. The anti-CGRBs. Well, listen. It was approved only in the it was approved in 2019 in the US. 2019-18. It was in the market by I think 2020. So we're having about 6 years of experience. 4 or 5, 6 years. So I'm not sure what kind of drugs is this in 20 to 30 years. Wallah, we don't know.
Just to emphasize on one point that we know that even from the manufacturing company that aprogepant, you cannot exceed 16 tablets per month. 16 tablets per month. Yeah. Mm-hmm. So what is your approach if you...
Most of them, most of them who come to me, they end up taking 5 to 8. I've never seen anyone who take more than 10.
Okay.
Yeah, exactly. Even this is my experience. Most of the patients, they will not exceed maximum 7, 8, not more than that, especially if they are using any one of the preventive medication.
Can I just say one comment?
Yeah, please, go ahead.
I'm not advocating anything against this medication, but I'm just being honest. I don't think they should be taken for life unless the patient wants it for life, but I'm advocating 100% for anti-CRB safety. Safety is amazing.
Yeah.
Safety is amazing. Side effect profile is more amazing. Literally, I've never come across any patient who come to me, you know what, it gave me this side effect, except the injection side, عورتني شوية which is once a month.
Yeah.
But I've never come anyone that I couldn't tolerate it, became dizzy, became short of breath. Never. I got out of, maybe I have 200 plus in all anti-GRB. Out of them, maybe I had 10 to 15, 20 say they stopped because they didn't respond. So then I question, maybe it wasn't migraine. But I've never come across anyone who said, you know what, it's a terrible drug, it gives me this side effect. Did you?
Okay.
Yeah.
And I believe we need to, even as a primary physician, we need to spend more time to get deeper in the root cause of the migraine. And not just only, as Dr. Saeed said, okay, well you're going to
This
give...
is my question for you,
Yeah.
Dr. Badr. Being expert in functional medicine, how do you find, the functional medicine can help patients with migraine along with this kind of medications?
Really, it helps. It helps a lot. Talking about taking deep history of the patient, I found many patients, okay, they have a big problem in their sleep pattern. Once you improve their sleep, many patients we underdiagnose of obstructive sleep apnea. We diagnose them with obstructive sleep apnea. It was one of the causes. Believe it or not, I have one lady, she's 30-year-old, and she was taking most of the acute and preventive treatment, and finally she ended by having severe allergy to oats, shufan, okay? And she is so healthy. When she stopped it, everything disappeared, and so on. So I believed digging deeper in the lifestyle, in allergy, in the pattern of life, or all the lifestyle we're talking about, sleeping, eating, playing, stress. Some of them ended by having a diagnosis of acute and depression and anxiety. And once you treat it, that's what we had patient. Maybe it's a connected patient between me and Dr. Saeed. I will share it with him later on. He's almost 61-year-old. All of a sudden, he has blindness. So we thought about TIA, we thought about stroke, we did ultrasound carotid. There was, by the way, 50% occlusion. He went to ENT, he went to ophthalmology, he went even to neurology, and he received all the medication. And finally, it ended by a psychological issues, not more than symptoms, not more than that.
Okay, thank you so much. I think the presentation was quite motivating for our attendees, and thanking both of you for the wonderful information that you have disseminated. And Dr. Karim, he's asking, how far can the primary care physician go with the full confidence to treat patient with migraine in the real world practice?
To the max.
In primary care.
To the max. The only thing, if he has any red flag, or if he noticed any red flag, or he discovered a flag, or he is not confident about the diagnosis, this is the time he should refer. And the referral is not only for neurology, as I mentioned.
And this is my question to Dr. Saeed.
Yeah.
How do you see the referral of the primary care physician for a patient with migraine to you as a secondary level? Do you think that the referral is justified, rational, well investigated, completely worked up? Yes? Yes?
When we talk about day-to-day practice, we know family physicians are overwhelmed and everywhere. So I used to practice في الحرس. They were extremely overwhelmed. Crazy clinic they see. والآن أنا في تخصصي طبعا I've been there, I've seen they are not as much as في الحرس, but still too much. They see a lot of patients. So let's be honest. At the end of the day, at the end of the clinic, you're overwhelmed. You would rather refer the patient rather than treat it. So do I get the patient referred from? And no, I'm sorry, I have to be fair to them. One limitation is maybe they see the patient will be appropriate for anti-CGRP, but the hospital policy limited as to us.
Neurologist, yeah.
But in general, if I think, and I'm not really saying this. لأنكم قدامي. I don't think migraine is something that in almost always, I'm not saying 100%, let's say 90% of the patient, they can be served very well under a family physician, or even a general, like me, a general neurologist, who will end up needing specifically a headache specialist. I think it's a minority, 10%. And the bottom line, if you work in a hospital where you as a family physician have access to neuroimaging, you're set. What's the worst thing can happen? You know what? I'm not confident. Let's do the MRI or the CT. If it's clear, it's clear. You're done. You almost ruled out anything serious. If it's 50 plus, you do the SR, CRB. It's not Janus arthritis. You're done. You're left with nothing else serious to miss here. So if you are a family physician, you have access to neuroimaging. I think go full blown. Treat them all.
Okay.
And I'm sorry, and when I
yes.
say treat all, treat, if the patient failed the first line, don't refer. Try the second. Third, maybe after third you refer.
Yeah. In the real يعني word ground, many of the primary care physicians, they exhaust using triptan and NSAIDs. So what is your strategy to overcome the medication overuse headache using the triptan? If there's any strategies, how limitation you can go step by step, and because it's very
Medication,
common.
I just tell them. The first time they come to me, I tell them be careful. There is something called. يعني بالعربي أقول لهم انتبه في نوع من الصداع بسبب مسكنات الألم.
صحيح.
ودائما طبعا you know the criteria say 15, so I never tell them 15 days. So I tell them لو ايش يصير، وحتى يعني اخذها بالايتام اقول له حتى لو تربط راسك تربط بالجدار، حدك 12 يوم في الشهر مثلا اني انالجيزك، حدك 7 ايام مع انه by the criteria 10 days، حدك 7-8 ايام تربتان. So I educate them about them and I scare them a little bit about it. Nothing in a serious way. I tell them, listen, this is very difficult to treat. If you have it, you will make your life terrible and my time difficult. So it's all about education.
Okay. Dr. Saeed, what is the profile of patients that we can يعني start CGRPs and GPANs at once? The patient profile. How is the presentation of patient that you say this patient need a GPANT?
Now,
Yeah, immediately.
برضو honest,
Yes.
my only limitation is the cost.
The cost.
If the cost is not an issue, what's the point of using, unless, I have to be honest, let's say.
But we don't have
Let's
the problem
say
with the
I want to
insurance.
use a preventive in a young lady who get the migraine 3 days per month. And it's never disabled. يعني ها شوية يعني ضميري يحكي أقول لي let's try Inderal, let's try. But Tolomax I almost stopped using it, although it's very effective. Effective, but the side effect profile is terrible. Amitriptyline, most of the ladies, most of the patients are female, they gain some weight and become dizzy in the morning. So honestly, if course is excluded, it almost always anti-GRB.
Okay.
Almost always. Yeah.
How do you identify your patients who will be benefited from the preventive therapy?
Oh yeah, I'm sorry. So as per the criteria, anyone 3+ with disabling headache or 5+, no matter disabled or not, they should be considered.
Okay.
Yeah.
Perfect. تفضل.
What is the justification for the
insurance؟ لا so good point.
لأن rejection
I've
عالي.
never طبعا في ناس انا الحين في السلامه في المستشفى ففي السلامه في وحتى ضمن في الاي ام سي في مثلا من ال 100 مريض في يمكن 10% they have something exceptionally VIP insurance. I don't have to put any justification. اكتب headache اكتب تريبتان اكتب I'm sorry Progebant. Most the other 80% no. You have insurance will never, as my understanding, they will never ever accept it as first line.
You need to go throughout the scale. You start with
Yes.
Triptan, others.
So if it's left to insurance, they will never accept it.
Using the high dose of triptan and patients subjected to medication overuse headache, this will be a justification.
Or
to
a side
start.
effect, or
Yes.
endo palpitation,
Cardiovascular
hypertension,
patients,
أيوة.
yes. These contraindicated patients, definitely we can go for.
أيوة.
طيب, okay, any other questions? I think we have reached the time now where we can.
The last question, Dr.
please.
Said approach in dealing with pregnant lady with migraine. So I had one case like this. So I struggled with this case. So I refer the patient to the pain management. I discussed the case with the pain management. They said the only safe thing, and this was the action at that time, they gave her on-spot nerve block, and she was free. Is there any other approach from medication from your experience, Dr. Said?
Propranolol. During pregnancy, propranolol should be safe. It's almost always safe.
Okay.
That's the only one I use. And steroids, PRN, like oral or IV steroid within 21 days or IV for the acute should be safe in pregnancy. Yeah.
All right, so I think we are coming to the end of our scientific event. I think it was quite interesting for all of us, and I have received a lot of questions, and a good thanks from the audience for both of you for the wonderful, rich scientific data that you have shared with us, and even you have shared with us your clinical expertise. Ladies and gentlemen, I would like to thank on your behalf Dr. Badr bin Hamd, Dr. Saeed Al-Ghamdi for their wonderful contribution, and I would like just to remind you that we are, as a primary care physician, we are in a position to look after patients with migraine. We have all the tools, we have all the medication that we can use So we can go all the way ahead and give the patients what they deserve to improve their quality of life. Remember that migraine is quite prevalent in our clinical practice as a primary care, and at the same time, it is disabling and dysfunctionally, medical entities, and our role is to provide the patients with this kind of remedies that can improve the quality of life. So we can use the CGRPs, triptans, and aprogepant, one of the molecules that we can use. And we have a very good experience by many of the senior consultant family physicians. We are prescribing it, and we are getting the benefits, and we are getting the feedback and the reward from the patient themselves on improving their quality of life. So I hope what we have learned today from our experts that can be implemented to our day-to-day practice. So carry along with you these data, these expertise, and implement it tomorrow onwards to make the change that we would like to have in the life of our patient with migraine. Once again, I would like to thank you all. We thank the Saudi Society for Family and Community Medicine, and would like to thank AbbVie for the wonderful organizations and the fixes for organizing these sessions. Till we see you again, ladies and gentlemen, I wish you a very good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
you.